Good afternoon, everyone. I would like to share with you something beautiful. I am the co-organizer of this conference for the past 12 years. I remember all these years we've been discussing how we can organize a good procurement strategy and system in the Greek health ministry. They were endless conversations with no end in sight. 12 years ago, I could never have imagined that I would be moderating such a roundtable. So let's start on an optimistic note and say that this roundtable is the hope for a modern health system that walks hand in hand with the fourth industrial revolution. I would like to share with the audience that all these people who are with me on this panel, all these brains we've managed to gather here today, are capable to let us and walk us through the next step, which is a modern and effective procurement system. I want to thank them very much for all the work they've done on behalf of the industry. We will start with Mrs. Theano Karpodini. I think she's the brain behind the health system, because you are the governor of the EOPYY. So you are kindly requested to take the floor. Thank you very much. I would like to thank you very much for this invitation regarding the partnership of the private and the public sector and to have procurements in the public sector. Like the coordinators said, the moderator said, the people who are here, each from their own post or jobs or whatever, not just the EOPYY as the brains, each of us, from their own jobs, from their own posts, fight a battle in order to turn a new leaf in the way we purchase services and products and drugs in the health sector. And indeed, a necessary requirement is for all of us to be together rather than everyone on their own. As for the EOPYY, as provided by the competences for the organization that was created in late 2011 and started its operation in 1st January 2012, all the bits and pieces of the old insurance social security funds have to do with health came together. So the organization's profile and its key destination is to purchase products, health products and services for all of its insured parties. This means that we need to evaluate and assess the needs, to design and plan rules which will enable it to negotiate and determine and define the targets so as to cover each and every need of the insured parties, be that for pharmaceutical coverage or primary and secondary health care. It is within scope and within this framework that we have the main goal of enabling it to assess and enable the decisions they make on the basis of effectiveness, efficiency, quality criteria, and equitable access of the insured parties. Subsequently, the bet or the wager is for this to be depicted in the contracts entered into by the organization on the basis of specific criteria and terms, to incorporate all these elements and these parts that I already mentioned and are required to be there when you're called upon to purchase health services and to manage public resources, the insured person's money, taxpayers' money, so as to ensure that they will receive all the treatment they need. Any pharmaceutical treatment is appropriate for their ailment, and obviously medical technological products. We have the chairman, Mr. Papaioannou, the chairman of the negotiation committee for the reimbursement and prices of healthcare services. With the negotiation committee, I believe that we have already managed to have an immaculate collaboration. For all this time that we've been working together, The committee has managed, with the participation of the organization's staff and agents, and I will mention some examples subsequently who I mean, we have managed to succeed and achieve our key goal, our key target. And that is to receive more services at lower prices and of higher quality. And so as not to be misunderstood, I do not mean clawback. I mean volume agreements, I mean quality criteria, and all these things that Mr. Papaioannou will undoubtedly mention later on. Similarly, we have a very good collaboration with Techni in order to move forward with a new pricing and costing system of secondary healthcare services. Pilot programs are already underway, and I believe that by this time next year we'll be in a position to include all public hospitals in this system progressively, and for the organization to manage, and this is the big wager, the big bet, to pay the reimbursements in a new way on the basis of quality criteria and following evaluation and assessment of the results of the services received. Moving forward, I'd just like to share a few numbers with you to illustrate exactly what the EOPYY is called upon to do with 105 service points all over the country, with approximately 1,500 employees, with contracts with 35 providers, which includes 11,000 pharmacies that are reimbursed for the pharmaceutical expenditure, the high-cost drug pharmacies, 3,500 centers, physical therapists, other services, of course primary and secondary healthcare structures in the private and public sector. And with all those, we have entered in contract so that 11 million Greek citizens may have equitable access to health services, pharmaceutical treatment, and medical technical equipment. Another big wager, a big bet, is to remain within the confines of our budget, which is approximately 7 billion for health services and for pharmaceutical expense. Now, our vision is to manage to become a strategic buyer of health services, as I've called us before, and rather than a passive one. So our key goal is to have high-quality services for our citizens by rationalizing and streamlining the reimbursements we disperse, with emphasis on the public health care system. And the reason I'm saying this is that in Greece, Greece is the only country which ensures access to all citizens regardless of their insurance status, of how much they pay for their insurance or their social security. And this is a tremendous wager, which naturally could not be met had we not had the public part in primary and secondary healthcare. Our vision is equally to see the organization as a modern, socially sensitive banking institution, because, well, the organization is a social security fund with revenue, which is the contributions of the insured parties for the health sector. And our goal and our aim should be, within this framework, which is already and always a limited one, to find the most efficient and effective way to ensure everything that is needed by each and every citizen of the country. As for the EOPYY, and I'll try to be concise, a little brief, the contract process is a very simple one, actually. First of all, what it takes is design. We need to set our targets, see which processes will allow us to achieve them, and a key strategic goal for us is to purchase more of higher quality service at lower prices and streamlining the distribution of the small and absolutely finite, unfortunately, budget. What comes next is practice, action. How this, in collaboration and consultation with our providers through our contracts and following quality features, characteristics and indicators, will be able to receive the best possible services, the most effective ones, at the best possible price. Mrs. Karpodini, you have 1 minute. 1 minute it is. So it is within this framework that we implement and control and monitor, because I need to say that this is the most important thing. We monitor and assess and evaluate the effectiveness and efficiency of the expenditures we make, the expenses we make. And I'll give 2 examples later on. And we are evaluated on this. I have to stress that we have the joint framework of evaluation, and we're evaluated both by the providers and our insured parties, so as to be able to improve the way in which we provide our services. So payments is the monitoring thereof allow us to increase the efficiency, the effectiveness. What we're trying to do, and here I will mention an example which I credit to the negotiation committee and the chairman thereof, Mr. Papaioannou, that we managed to succeed to reimburse gene tests for breast cancer by securing and ensuring that chemotherapy will be administered only to those women who really have those features and characteristics that make sense and can be helped. This is huge. And this is what we do through the diagnostic tests. We direct and guide treatment better to make it more effective and to avoid administering when it doesn't really make sense for the women. Now, apart from the financial benefits, we have the social indicator. We avoid having the consequences of a treatment, chemotherapy, using poisons, for instance, and all the social exclusion and the ordeal for approximately 80% of the women who manage to avoid entering into this process. I will not enter into the numbers for the economy of time. I will just say that the negotiations committee regarding diagnostic radiological drugs managed to open the market and to avoid monopoly situations, which in turn resulted in an agreement that dropped the price by approximately 1/3, I believe, saving up a significant chunk of the budget that was allocated in order to enlarge the indications and broaden the indications and allow more citizens to have access to PET CTs. These are examples that prove in practice that the future and our goal is to combine quality and effectiveness through control. What we want is not only to buy a hospitalization or a treatment or a care, but to see the results thereof, the complications of the patient, whether they needed to be readmitted to the hospital. We want to pay for the drugs as a function of their clinical effectiveness and efficiency, and to move on to the day after, in which we will ensure high quality and effectively funds that we can channel to more actions. I believe that I have already spent the time at my disposal, so I will yield the floor, and I will be around to answer any questions. Thank you very much indeed, Mrs. Karpodini. It was really very important things that you've done in the EOPYY all these years. And it was really impressive, and we heard someone saying yesterday about the management of the data. It's something really innovative. It's pioneer stuff, and thank you very much for it. Let's move on to Mr. Apostolou, president of the EKAPY. He's the new guy in procurements. Okay, so you have the floor, sir. We're eager to hear what you have to say.
Let me also thank the organizers for the invitation and the opportunity given to me to say a couple of words about the agency I represent vis-à-vis the procurement policy over the next years. If we consider that the whole procurement system of the Ministry of Health is an operation, the Logistics Directorate is EKAPY. For those of you who know logistics, you know that the role of this directorate is to support all the other operational processes for the optimal result. The National Central Procurement Authority is a development of EPI. It is called EKAPY now. It is now a legal entity so as to have greater freedom of movement. And the goal is to have central procurements in the field of, in the sector of health. Our vision is to create a modern and reliable agency that attain its goals each year at the level of central procurements. It is worth noting that EKAPY in 2019 employed only 7 persons in 2019. Today we have 60 persons employed, with 13 executives recruited from, actually transferred from the agencies of the Ministry of Health, and 40 persons who are ancillary personnel. In 2022, we have completed procurements codes of interest of 87 million euros, while until tomorrow we will have completed e-auctions for medicines of 224 million euros value. These days, we also issued a call for tender for medical cotton, which is a case study. Indeed, may not sound very important, but this is a first call of interest to see how the system operates. We created a site which will evolve into a communication portal along with all the other agencies of the Ministry of Health for the exchange of data and digitization of our communication. And by the end of the year, we program new calls for ATAVI, stroke units, cochlear implants, and lenses, intraocular lenses. On this process, we have selected for cochlear implants to have central procurement and central distribution on a pilot project so as to see how this operates on our own budget, and we will be sending with an invoice each hospital the delivery when it is needed. At the same time, we prepare the strategic plan of procurements for 23-24, and the big project currently under maturity, and which is a major reform, is a central pricing of hospital medicine, where through a digital system, all the orders placed by the hospitals will be executed through our agency, through our directorate, EKAPY. The goal is to reduce the workload of the accounting departments of the hospitals, but also reduce the arrears, thus attaining a great improvement in the central indices of the Central Accounting Office. In immediate plans, we include the launching of a project for a single codification, most probably following the Italian case, as it will be applied in the whole of the European Union. As we said, in order for the interoperability of the systems and their interface, we must have a single language so as to have an exchange of data and make the appropriate decisions. We were also assigned the responsibility for the feasibility study for medical equipment. We are to issue that so as to gradually proceed in mapping of all the machinery equipment currently under the national health system. Within the year, we will also be recording the consumables so as to be able to monitor in a more secure way the execution of the contracts that are affected by the hospitals aside of the central procurement system. I lost a slide somewhere, says the speaker. I would also like to say that in the framework of RRF, as an execution agency, we were assigned with the medical equipment for the upgrading of the health centers, while yesterday, during a discussion with the political leadership, it was also decided that we will be assigned with equipment for hospitals as well. Both projects exceed 120 million euros in budget, and we look forward to proceeding right away. In the same framework, we will also be the execution agency for co-funded projects through the NSRF, so as to also help there. One more minute. So, let me conclude by something that will also facilitate the continuation of the discussion. Well, at the end of the day, we're currently at a point where we can plan, we can draft the calls for tender, but we want to move towards a value-based procurement. And in this panel, we have all the representatives that will be the rings of a chain, so as to have an effective system. Thank you. Thank Mr. Apostolou, and once again, I'm glad because through the discussion, we have again the same notion appearing, the value-based procurement. Eventually, we might be able to apply it in Greece as well. And now it is the turn of Mr. Messaropoulos, the president of ETECHNI, that is a Center for Documentation and Pricing of Hospital Services, who will tell us how he created this wonderful project within the DRGs.
Well, I believe that in the first year we pinpointed where we are, and we announced from here that we are being included in the DRG system. It's the first health district that uses exclusively DRGs. I decided to skip the slides because I wanted to leave a lot of time for discussion. What I want to do is to say and mention a few things regarding the synergies, regarding procurements and how a DRG system is involved in procurements. And it plays a role. Now, the DRG system may not be the most perfect one, but it's the most fair one, as it with the hospital's reimbursement. The purpose of introducing a DRG system is to reduce the costs of hospitals, but better put is to see at some point how much hospitals cost us. By introducing this system of the diagnosis-related groups, we will try that the money we have and we disperse to the hospitals through the EOPYY to be shared and distributed among the hospitals in a much fairer way. So the information input in the system needs to be reliable. So this was a key question we had when we started the creation of the system, which is why we performed an innovation to link the DRG system with the patient's personal health record. We were looking for information at the source. What is the source at the hospitals? It's the doctors. But for the doctors to be able to depict and describe actual information, they need their own system. As a doctor, we know as a healthcare professional, but most people in the field, that a doctor will write down the most reliable information in a single record which is theirs to use and will help them later on. So in essence, we wanted to receive this information through this patient record. So we wanted to have the information from the beginning, from get-go, not in a secondary system where the doctor would just enter some information which most of the time do not correspond to the truth, to the reality. This is what we did in the 7th Health District, which this is what we're expecting in anticipation of the second, or rather the third ministerial decision after the Parni and the region of Crete, the third joint ministerial decision that is at the Ministry of Health. I believe it will be signed by the end of the month. The full introduction and inclusion of the third health district of the EKAPY hospital from the 5th, the General Hospital of Volos, the General Hospital of Larissa, and the University Hospital of Larissa, the Thriasio, the Red Cross, and the first district of Athens, that of Syros, and the Andreas Sigros Hospital. Now, we moved around some key pillars. First of all was to receive all the information from all cases so as to be able to utilize them. The second pillar was the assessment and evaluation of this information, which is why the EKAPY is running an NSRF project. They will be checking 200,000 cases one by one using a special platform in collaboration with the EOPYY, so as to see how our colleagues codify the information and how the information introduced in the personal health record is utilized. The third pillar is training. The EKAPY has not ceased offering training. In all hospitals of the country, one of them ran in all hospitals. It was a participation of 75%, which was huge. Or in the RRF, which is subsidized training for all healthcare professionals. We have the asynchronous training for everyone who wishes that to be trained in billing or codification at any time that suits them. The fourth pillar, and this is what Mrs. Karpodini she gave away what we're discussing about. It's reimbursement. Okay, on the 1st January of 2023, we are preparing all the necessary regulations to allow at least the 7th health district to enter in the full reimbursement through a DRG, and a full introduction and inclusion of all the hospitals in the DRG system. Now, this is still to be implemented. I hope, having a very close and good collaboration with the Ministry for Health and the EOPYY, to be able to make it a practice, so as to have the bigger picture and to have a full and complete DRG system within the next year. Now, regarding synergies and procurements. For us, DRG is not just about reimbursement, it's also about innovation. And innovation is something that touched us very much from the beginning, which is why we're doing what we're doing with the personal health record and the codifications. Already the EKAPY has undertaken all the codifications that are out there in the health sector, same as the EKAPY codifications will be handled by the EKAPY. It's a development of the EKAPY actions that was adopted by a recent amendment to the law. So as for all of us to share a common language. An agency that will need a specific codification will have to update the EKAPY, inform them, and they will provide them with the codification, be they made by the EKAPY or EOF or any other agency. So we're in constant communication with Mr. Apostolou from the EKAPY to be able to find the link between the procurements that will be run by EKAPY and reimbursement. Also, regarding innovation that I mentioned earlier, there is a big difference in the DRG system, and this is called exceptions file and list. We all have experience from the EOPYY for some accepted and excluded drugs. Now, the difference in the DRGs is that primarily as regards materials, this price does not reflect the material itself, but it reflects a whole service, and primarily innovative services. Because in this price, in inverted commas or outside inverted commas, it's not just the reimbursement of the material, it's the reimbursement of a colleague who is more skilled to offer this innovative treatment, a nurse who knows how to handle the material in question. So we're talking about an entire different mindset that introduces innovation. These lists will be analyzed by the KETECHNI in collaboration with the EOPYY on an annual basis, so as to be updated, to be renewed, refreshed, and to see whether something needs to stay in this file of exclusions or it should be included into a DRG directly. This is something extremely important because we have a system that is dynamic. This is no longer a system that is installed and it's fire and forget. It's a dynamic one. So this dynamic character requires synergy. Now, I don't want to take up too much more of your time because we have 28 more minutes and I want to leave space and time to my fellow speakers, and I want to leave time for discussion. I want just to say that research in the UK, Switzerland and Germany, I should like to remind you that with Switzerland and Germany we have the same DRG system. There is pressure to reduce cost through DRGs. Through the studies, one can see that this does not necessarily mean a reduction in the quality of the services. The DRG are here to add quality to the services, to make hospitals, to incentivize hospitals to show their productivity, and since they become more productive, to receive a better reimbursement, because this is what we're looking for, isn't it? Thank you all so very much. Thank you, Pantelis. You are always cohesive and to the point. Let's move on to Mr. Balanis, CEO of the ODIPY.
Good afternoon. I thank the Chamber for this honorary invitation. It's a great joy for me to be here along with this excellent panel of speakers representing ODIPY, the organization that was established 2 years ago with a view to being a regulator of the health system in the country and introduce the notion of quality, a notion that has been mentioned by all the previous speakers, and it is extremely important for the improvement of our country's health system. ODIPY was established 2 years ago. It is a tangible improvement of the national health system that we have at large an organization that has horizontal responsibilities for the whole health system. And since we have these horizontal responsibilities in improving quality, we cooperate with all the agencies involved in the health system so as to improve on joint actions the quality of health services. We have already launched synergies with organizations such as KETECHNI. From the first year, we have signed an MOU with them, and we have aimed at a number of actions with a view to securing the best possible platforms for the improvement of healthcare services. These can be seen on two axes regarding also our strategic plan. On one hand, we aim at securing the health services and improving their quality. On the other hand, is the introduction of the strategy for health. With regard to strategy, we mean the creation, production, recording, and monitoring of data. So in the case we don't have data, to help in collecting them, and monitoring the health services offered and how effective they are. On the other hand, securing services quality can be originally secured by the creation and introduction of quality indices, that is metrics that did not exist in the past. We have already launched actions, have created indices, quality indices, more than 29 currently, that can be distinguished on three branches. We have safety indices, effectiveness, and efficiency indices. Those indices are applied on a pilot project with all hospitals with a view to extending them to more hospitals and health centers so as to cover all the needs of the edges of the country and be completed by other indices that will be introduced by the patients that will record, therefore, the experiences of their patients and their satisfaction rate. All these are funded by both natural resources and European Union sources. We work on national projects for the improvement of health services, for the introduction of quality indices, and the cooperation with the other stakeholders and health professionals. The organization, ODIPY, has already launched the so-called patient pathways. It is important when we speak on quality. Since we each have an important part to play in the health services, it is important to see the pathway from the processes, that is, end to end. And since we have the horizontal monitoring of this process, we want to record, map, monitor, and record the pathway of the patient. So there are parts of assessing the quality on the orders of the equipment, on the part of services offered by health professionals. So all in all, it is a part that must be examined, and we must have as great an effectiveness and efficiency as possible. This will only happen when we get the views of all the stakeholders, including the patients, of course. Patients, to a large extent, play a role in this process. And our goal is to have cooperation with the patient society in Greece, its association, and be able to have their views on the health services they receive. On the other hand, we'll launch the procedure of modeling the services. So through co-funded projects, we start with the modeling of the patients, of the HIV patients' pathways. And this will cover more than 10 hospitals in the country. That will be a first patient pathway that will be modeled. That means that both the equipment offered and the care will be common in all hospitals of the country. We also overview the improvement of infrastructure. It is also an important part. And here ODIPY will help in cooperation with the existing agencies, will help in improving the infrastructure of health services in our country. We also have primary care. We are also responsible for that. We already record improvements. We see the introduction of the general practitioner, a family doctor. Soon we will also have the home care, and ODIPY will support that so as to have the appropriate funding and change the path for the care of those patients as soon as possible. All in all, because we've also had the value-based procurement, which is most important and concerns the framework within which we must operate, so as to bring efficiency in the ordering process, so as to have the best yield with the less possible resources to be used for each order. ODIPY will help in have a general picture of the value-based care This is a part that concerns not only the value-based procurement, but the whole picture of healthcare for the best possible qualitative and efficient service. And of course, we will have cooperation with the academia, the methodology applied by organizations in other countries in the whole Western world, so as for Greece to be part of that and have these processes as soon as possible. Thank you. Thank you, Vassilis, and we'll conclude with Mr. Papaioannou, the President of the Price Negotiating Committee.
Thank you very much for the honor of being amongst you. And I don't know whether we can put up the presentation, and I'm rather stimulated, Mr. Liakopoulos. Oh, please refrain from sharing that embarrassing information. No, I meant stimulation because we're talking about strategy, procurements, and combining forces. Now, I imagine that the President and Governor of the EOPYY would give more information. What I would say is that what we're trying to do is for these forces combined to be multidisciplinary. This has been depicted in the organogram of the EOPYY, and the Reimbursement and Negotiation Committee has a very diverse profile of scientists that is very complementary and helps in an integrated approach. So in multidisciplinarity, I believe we're doing very well, and the more new sciences, specializations and AI emerge, the more new brains will be needed. What is also very important as a strategy is international collaborations. There is a national contact point with the EOPYY. Whenever we needed them, they were at our disposal. And there was a response from European countries and our opposite numbers, and there was a request for information. We could do something even better. Of course, this international interface has much room for improvement because there is not always this anticipated response on their behalf. Another value is in the link and the connection between the private and the public sector. When we're talking about procurements and negotiations, the other side of the table is well populated by the private sector, but it would be worth it if we could utilize knowledge from private insurance companies, private hospitals, and I'm afraid we're not doing that well. We don't know what happens in other sectors other than our own. It would be a very fertile thing to have, well, not the confidential information or the ones that would impede competition or hurt competition, but the one that is public domain and that have to do with methodologies and the way of thinking. So we do have a long way to go. We don't want to paint a very rosy picture. It's not just collaboration between and among people. It's between man and machine, man and computer. We heard about artificial intelligence, patient registries. These systems need collaboration with us, the people. And I think that sometimes we don't have a perfect relationship. We do not feed these systems with proper information, with high quality information. It's Kika, and it's a miracle how fast Greece adopted this system, and they can become better. There was another word tossed around. It was interoperability. So there is a connection and relationship between the machines, between them, and I believe that there we can invest in. Within the EOPYY, we do have this interoperability, and whenever we needed information, statistic information, there was a very, very fast response. It's impressive for a public sector agency how fast these departments respond and feed us with data. But when we leave the confines of the organization and we need information from EOF or EDICA, and we need data to complete the picture we have for effectiveness, for instance, like Mrs. Karpodini mentioned, or efficiency, or how successful is the outcome of our procurements in health or public health. Well, there I think that we find it a little difficult. There are some legal constraints, maybe technical ones as well. Well, in conclusion, I would like to say that an effective and efficient strategy is not something that goes without saying. What is effective and efficient for health is multifaceted. Are we talking about the individual's health or that of a society? The freedom of the person or our social obligations? What are we talking about? A society has its own perspective regarding the effectiveness of what we're doing. I've been with the EOPYY for 2 years. I always see open doors to patients' associations, to groups, and not only their individual requests, groups of people who have requests, complaints. And it is our principle in the negotiations to listen to the society, not just the other stakeholders. Effectively, nothing can be always effective in financial terms. If it's something effective for EOPYY, it's not effective for the profiteering, in a good sense, of the companies. But we need to find convergence. We need to find consensus, where everything, all the ducks are in a row, are when the state comes in and says, bring everything down and create a different framework. So this is usually fertile for long-term approaches, but in our microcosm, oftentimes it's, not bothersome or irritating, but it does create the need for another approach. This is all I wanted to say, so as to leave Mr. Liakopoulos time for discussion. Thank you very much, Theo. Right, well, we do have some questions which we will ask. One question was concerning what you mentioned, the combination of forces and joining of forces. A question is to see how all these efforts and attempts made by all these agencies, EOPYY is a central agency, you have the negotiations committee, but as for DRGs and EKAPY, at some point, and we would like to know which point of time this will happen, these efforts need to converge to a single direction for the good of the patient, for the good of the health system, and of course for the industry to see this high quality that we definitely all want in the system in our hospitals. I don't know, do we have any takers, Mrs. Karpodini? Because, you are the central framework. I think you were spot on that this is the bet, the wager, how we can all cooperate so as to achieve the common goal. Truly, collaboration is there, as far as the EOPYY is concerned, with each and every agency, depending on the project we're running and the timeline. But I think that if we are all together, to be all together in a project and work all together is not something we've seen so far, and it's something we've conquered. I think that the ministry's design is to move to that direction, to force us all around the same table, each to do their little thing in service of the common goal, which you quite aptly put the efficiency, the effectiveness, better services, health services. But what we're trying to get through all this is benefit. Benefit for our providers, benefits for society. Because truly, in this effort we're making, we have them as our allies. And they're our allies because, what company doesn't want us to progress in terms of drugs, for instance, or to examine the feasibility, which in turn increases effectiveness and efficiency of the drug itself and the treatment. So yes, I wholeheartedly agree. We have made a lot of steps in that direction, but many more need to be taken and collaborated, not amongst ourselves, but also with the other agencies. Your project is running very fast, and it will be completed at record time. So, let's say that your project ends, we can see the DRGs implemented. What happens next? There is the day after. First of all, let's make one thing clear. When we're talking about DRGs, we're talking about cost weights. What are cost weights? They are the cost weight variables. In essence, this translates to how much more difficult or how much more complex a DRG is compared to another one. These cost weights we have borrowed from the Germans. We've been revising them constantly. They were revised by the Germans in January 2022. I apologize, there's a speaker, January 2021. We did a revision through the RRF, and they will be constantly updated. So we don't do detailed pricing. We don't know exactly how much a DRG costs. We know that a DRG is more complex than another one, so it's possibly more expensive than another one. But we are building the day after, and we're looking ahead, and that's what's important. We're already preparing to have all the tools so that at one point we can do this detailed pricing. Most of us are in the field and we know how difficult it is to do pricing, actual detailed pricing. I'll need to say this. Switzerland, and we all know how organized a state like Switzerland is, tried to do a detailed pricing when they received the DRG system from the Germans. We have the same thing. And after 2 years, they went back to the Germans and said, I can't do that. Give me the cost weights and I'll move this way. There will be cost centers. We're already in contact with specific hospitals. One of them is the Parni on Crete to come up with indicative costs. We're talking with people abroad to receive know-how and IT systems that will allow us to perform this analysis, which later on will allow us to do the full analysis, complete analysis of everything, and say that DRG-A costs X amount, so the hospitals need to move according to this price. Or later on, this price might increase or decrease, which is why we talked about the dynamic system. Something very significant regarding procurements. Now, we'll have EKAPY who will have tenders for cotton or other materials or anything. Be that material in an excluded materials list or an expendable item. Regarding the excluded ones, well, some hospitals will buy at a price X if it's not through this, and other hospitals will be off the list. The lower the price until the revision, obviously this saving up of money will stay with the hospital, so it will be a benefit, in inverted commas, for the hospital and an incentive for the hospital to save up on resources and expenditures. If it is within the DRG, in the analysis we will perform within the year, we will see whether something is of benefit to the hospital or not. So saving up resources is something that plays in the entire range of the process of including hospitals in the DRG, right? Either here with the cost weights or later on when we hope to have the detailed pricing. So it's a huge opportunity, okay? There's a huge field that's open ahead of us, and this is why we're discussing. To be able to offer the higher quality services possible for the patient, for the citizens, and at a cost that will be real. Mr. Apostolou wants to say something.
Off mic. To my view, we cannot raise an issue of confidentiality between agencies of the central government. We all operate with a view of public interest, securing public interest. When designing this cooperation that we try to attain, in my view, there is a code, a single code for the material. Within 6 or 7 months, most probably we will have finished that. This material code, then in the next stage of interconnection with hospitals, it will be all over the country. It will be participating in another code of DRG, which, however, for each act, medical act, might be transformed, might be modified, because it might have another piece of material on a different code because something different will be performed with the physician. All that data are mentioned, included in DRG. At the same time, EOPYY has all the submissions per patient's registry. So with regard to expensive materials, you can see how efficient it is. We will be buying a graft, for instance. Did it last for 3 years? That's why I bought it. That was a prerequisite. Or did they ask for a spare part within 2 years? These elements on the series that are being analyzed by ODIPY, when we will be relaunching the procurement or make some kind of correction, I consider that we can include qualitative data in the system in an integrated way. Well, Madam Karpodini, there are a lot of questions to be addressed to you. A first question will be addressed by our friend Mr. Apostolidis. I'll take the example. I congratulate Mr. Messaropoulos on his decisiveness and what he has done. He said that the 7th will have it in due course, and all the other regions will have the DRGs. And I would like to address a question to Madam Karpodini and Madam Fotiadou here of EDICA. We do have data, which unfortunately Mr. Apostolou commented, which unfortunately in the pharmaceutical innovation are not available. We hear nothing about that data. And I would like to bring the example when for the first time EOPYY was established under Odysseas Voudouris, they saw that the first medication was not something for hypertension or against cholesterol. It was a medication, a medicine for autoimmune diseases. So in surprise, thought there was some kind of squandering here. So transparency and exchange of data, and the way we can do that through the pharmaceutical vigilance committee, which is in the ministry, will only bring about benefits. And the continuous counter-argument is that we have the therapeutic protocols, DRGs, and so forth. I believe that if we offer incentives, as it happens in other countries, this can bring about a curtailing cost. So why don't we take the data regarding innovative drugs? What's that expenditure? What are the fields? Why are they consumed more in one region, not another? Or we can say geographical areas, if you like, more generic, not specific hospitals. Why do we have consumption in summer when we've got an increase of population and so forth? That is valuable data. And we all hear about EOPYY that we addressed the ministry didn't give us the data. When we will have access to that data at last? Of course, with the protection of personal data. Thank you for the question. There's a huge field for improvement as far as hospital medication is concerned. Unfortunately, we do not have EDICA there that you mentioned, and it is a common plea by all that we should by now be able through EDICA to have hospitals also monitoring medicines expenditure per cluster. Vis-a-vis the EOPYY organization, indeed, we have, but I will be very cautious here. We don't have a representative for the Ministry of Health, but we do have consultants of the minister here. There's a huge problem in this whole part of storage of data with a view to improving access to treatments through GDPR, because it was decided that EOPYY will not keep registries of patients. These are allowed only for the ministry to have, and unfortunately, we are denied the necessary access. And as you very well said, each time we have claims for data, both to the industry and international organizations that can help us, when we do not have our own forces do not suffice so as to process and draw conclusions, we are left outside. Our intention and effort is to convince both the ministry and this whole part of personal data management, the independent authority, GDPR authority that is, so as to do have access to that data. We must all jointly manage at last to have the picture where we'll all agree that this is the picture. Because we even have a problem with that. We cannot agree on what is the accurate image. And it is not the reading that is the culprit. It is that we do not apply common rules. We must apply and all agree that this is the way we draw the data and this is the way we can use it. But also something else Papaioannou said, that we must get out of our small world. They are not alone here. We do not have to reinvent the wheel. There are other people doing the same job. Why can't we transfer the know-how of the private sector, of the insurance companies, and all the others who, from another side, can indeed and are involved in the same subjects? They also buy services. They also buy medicines. They also calculate cost and effectiveness. So we must do away with this fear and open the doors so as to jointly find a path. Would you like to add something? Yes. Yes, says Mr. Balanis. In echoing what Karpodini has said, we have already taken an initiative so as to create a joint team, which I believe that should be a standing committee, where all the ministry agencies will be represented, all the agencies having data at their disposal, so as to first see what is the data we collect, how we collect it, and how it is being used. One of the first things I saw in this organization is the BI of the Ministry of Health. And what I can say is that I'm not feeling confident at all, seeing that whatever is uploaded, on one hand, nobody knew the methodology was applied, that is, who had fed the data, when, how, and on what methodology, and there was no accountability. So this is a part that I consider must be radically changed. The establishment of a standing committee where all the agencies having data will be represented. Mr. Apostolou very well said, we are all representatives of agencies of the ministry, so there must be processes where data and info might circulate amongst us, each one to see what one is supposed to see. All that can be secured. This is not a problem, it's not a technical problem, but we must know what the professionals, the health professionals, will be upload, because we may be asking for the same people to upload new data or the new data in different platforms, which is another additional problem and workload. I've seen it in UK hospitals where I've spent many years of my life. So we must see what the health professionals are going through. They're under huge pressure for us, asking us all the time new data to be uploaded, perhaps even the same data on multiple platforms, because we are not able to agree amongst us how that data should be uploaded, on what methodology and by whom, and what would be the accountability of each one, so as to be institutionally secure in the whole process. That would be the first step, so as to have the necessary data and give it to the market that must have it. I agree with Mr. Apostolidis 100%. The market must have that data. It is a part of the process of health service quality and respect of the work affected by all health professionals. Well, let us clarify something, says Mr. Papaioannou. there is a vector, it is ketechni, so they can also have a joint processing. The selection of the data, that's why I spoke of the medical file, to have reliable data and not have the problem of BI. Who uploaded, who said it, what had measured and not. Primary data straight from the source, so as to be able to extract important on morbidity, on mortality, on what is the medicines used, on the breach of certain medical practices in the hospital, small suitcases, we know that. So the data are of great concern to all of us. The reason why we try to have one single platform, draw all the data, and then divert it to all the other agencies, this is precisely why. And something last regarding the private sector. It has greatly involved the ketechni as well, and that's why we've got an MOU with the Association of Insurance Companies, with the Hellenic American Chamber of Commerce, with private hospitals. We had in a pilot project private hospitals integrated. We are already in discussion for the introduction of a DRG system in private hospitals as well. We have put the emphasis on the public hospitals, that's true, but they are not outside our goals. We have made our cooperations, we proceed. It was in the structured dialogue we had in the RRF to have the private hospitals included in DRGs. We are knowledgeable, we are a bit lagging behind, but it's of great importance. A question by, my name is Vourlaki Katerina, journalist from Daily Pharma News. First of all, I'd like to say that all that has to do with the patients registry, which is also a huge issue, which hasn't proceeded, especially over the last 3 years due to the pandemic. It has lagged behind. No, I disagree because the children's patients on neoplasma, on cancer patients, the registry exists. There are many registries that already we were behind previous years. I apologize. Okay, I stand corrected. Yes, I wouldn't like to be unjust. So let me ask Mr. Apostolou, this central management of resources, because actually this is what it is, and the market of materials, do have some estimate what will be the benefit at the end of the day, what we will save from this central management of resources? Well, there's no central management.
Now we have the central pricing of the drugs. Regarding the central procurement process, an average profit is around 20% when you're talking about a large volume procurement rather than having fragmented purchases. Okay, it goes without saying. One more question. Mr. Takis Maraletos, also from Daily Pharma News. I have one question for you, Mr. Messaropoulos. You said that we have the neoplasm disease registries and so on and so forth. What is the percentage of ailments that have been covered with registries as compared to our target? So what is the target and at what percentage are we now? First of all, responsible for the registries is the ministry, okay, through Mrs. Mitru, okay? I'm talking about codifications. Of course, we are lagging far behind, but what I said is that over the last few years, we've been running, we've been leaping forward. Now, first of all, we don't know the mortality we have from cancers in the country. Well, as Daily Pharma News, we had 3 conferences on evidence-based healthcare, and this has been discussed in detail for years, and we didn't have the chance of having you then with us there. I don't know whether you were working on it at the time. So for 3 years we were discussing the exact same things and nothing has changed. So now we have a plethora of information because there is tremendous information now. It is a great thing that we have here 5 organizations that you can combine and join your forces, and you can find the pathways and the costs and the processes. Now, I don't know how you can check and monitor hospital expenditures and the operation of hospitals, and this is an issue because I didn't hear anything said. Well, it will happen through the DRGs. But I also heard that in order, if we go to detailed pricing, it is highly difficult. And this is something you said, it's very difficult to go to detailed pricing. Switzerland went back to Germany and took their costs. Here in hospitals that we have provided very little data, I don't know what happens exactly right now. I imagine that the situation is even more difficult now, which is why I mention it. But your answer regarding registries covered my question. Now, I want to say this. You're waiting for 3 years for something. Well, we waited for 10 years to bring some people to talk about the day after in procurements, for the resurrection of this healthcare system that we've been trying to build for all these years. So their place here and their positions are crystal clear, and Mr. Athanasakis is shouting and he's sending messages. I would like to thank you very much for everything you have done for the healthcare system and the new effort for a new procurement system. Keep up the good work. Well, we will not wait for 3 or 5 years. You will have put them in place in a year, okay? We're always at your disposal. I think that the collaboration should be taken for granted. Thank you very much, one and all.